Hello, my dear friends. This is the fourth paper of the DNB December 2025 series. We have seen the earlier three papers. They were quite easy. They were like 80% questions were very straightforward, 20% were a little challenging. However, this paper is a little more challenging. There are some googly questions, no doubt. So overall, this is the kind of paper where your experience, your exposure, how well read you are was actually tested. And in some questions, you can create answers. That would be the expectation. But in some, if you don't have a clue, they are very difficult to attempt. But yes, definitely, I would say not 80%, but maybe six questions were very attemptable. Four had some tricky, some challenging, some new parts. There were repeats also, which I will tell you. But overall, it's not a paper in which you will fail easily. So don't get intimidated. But yes, it's a paper where you can't go with zero preparation. Some questions were repeated, some questions were new. So we'll do it in two phases. The first half is the easier one, so don't worry about it. But the second half was a little tricky, right? So let's get started. So here it's a very simple conceptual topic. Various ways to resurface a wound. Basically, how do you make a wound heal? Plastic surgery question. Then how do you harvest and put a split thickness skin graft? And why does a split thickness skin graft fail? So this is a normal question. This is one of the easiest questions of the paper. Now, whenever they ask you ways of resurfacing or basically healing a wound, there is one concept in plastic surgery that you should mention and write a few points about it, which I have shown in this very simple image. This is called reconstructive ladder. Basically, the ladder tells you what all options a plastic surgeon has to make the wound heal from simple to complex. So the choices can be simple, they are medium, they can be complex. That is the complexity as the ladder goes higher. So you describe all of them in little one to sentences, but basically this is the concept when they say ways of resurfacing a wound. When you go from down to up, easiest thing to do, let the wound heal by itself. That is called secondary intention. Or you suture it, which is what surgery we do in the skin suturing. That is primary intention. But sometimes wounds are very big, like a ulcer. There we put skin grafts. Or you can use bioengineered tissues, tissue expanders, like which are used in breast reconstruction. Or further, you can use flaps, local flaps, pedicle flaps, or free flaps. Free flaps are at the highest level of reconstruction that you can see. Free tissue transfer or tissue transplant means the same thing. Basically, they're talking about free flaps. So make this ladder, write one point about each. You'll get full 3 marks for this. Second part, how will you raise a split thickness skin graft? I am sure some of you would have definitely done this in your residency days, so it's not very difficult. Split thickness graft, you're harvesting the epidermis and some amount of dermis. Normally, the donor sites are going to be the thigh. If it's not adequate, you can go to the abdominal wall or to the buttocks. But thigh is where we normally harvest because you have abundant skin there. So first, the wound where you will put it, it should be healthy granulating wound. So normally in OT, we just debride it a little bit, ensure it is granulating, it is cleaned. Then the donor site on the thigh is cleaned, the hair removal and all is done. And then you start harvesting. Normally, depending on the size of the wound, you harvest a graft little smaller than that. So you harvest it, you must have used a Humvee knife. Nowadays, we have powered dermatomes. You harvest it, and when you are cutting the skin, punctate hemorrhages should be seen. Subacute fat should not be seen. If that is seen, that means you have gone full thickness. So you harvest. It should be smaller than the actual size of the wound because once you have harvested it, you make perforations on it. Basically, you mesh the graft so that whatever exudate come from the wound, they can be drained. So you perforate it, stretch it, put it on the recipient area and stitch it either with sutures or you fix it with staplers and you give a dressing with which will not allow the site to move for at least 4 or 5 days. That's it. A little bit of immobilization is needed, especially if it's a lower limb skin graft or site where you put the skin graft. The donor site heals by itself, so nothing needs to be done for that. Just a dressing has to be put. Third part of the question is graft failure. Usually it will fail if there is some problem in the recipient bed, like it is infected most commonly, or it has a lot of exudate or a hematoma or movement. And the worst thing, if there is poor vascularity. So obviously areas where there is poor vascularity, deep wounds where there is exposed bone or tendon, tissue is unhealthy, you can't put a skin graft there because it will get the nutrition from the recipient bed. So these are some of the causes. You write these 6 causes, you will get full 3 marks for this. So this is the question on skin graft. This is a new question. In the last 5 years, it has not been asked. This is something which either you know or you don't. Even if you don't, some things you can create. I mean, with some common sense. This is a urology or rather andrology question. And some things you can create. What my aim is not to tell you each and every fact, but to tell you how to write the answer, how to present the answer. Now, when I ask you causes of male infertility, don't write one, two, three, four, five causes. I've always told you when causes are asked, give some kind of a system, some kind of a structure. Like here, this is what is given in the books, pre-testicular or hormonal causes. Most important is hyperprolactinemia, pituitary tumors, hypothalamic disorders because of which gonadotropin releasing hormones are not produced, or other endocrine disorders, thyroid problems, hypothyroidism. Not very common, but can cause infertility in males. Then come to testicular problems. Usually testicular problems are very treatable. Like important ones, varicocele or testicular atrophy following a testicular hematoma or certain syndromes, Klinefelter syndrome, undescended testes, of course, or for any reason if there is a testicular failure. So these are the testicular causes that you should know. Post-testicular means in the tubules, vas deferens problem, or someone has had a vasectomy before, problem in the ejaculatory duct, problem in the cilia, like a cystic fibrosis mutated gene. So those kind of syndromes or those kind of post-testicular causes, they are the reasons where there is a problem in the pathway. These are the three main categories. The fourth category you can put as miscellaneous, like a erectile problem, erectile dysfunction, retrograde ejaculation after prostatectomy, but that will be seen in senior patients, or obesity, too much heat exposure, like people who go into a lot of steam sauna, they also are at risk of testicular failure causing infertility. Certain drugs and toxins, chemotherapy obviously can cause it. So these are some of the reasons. You give a structure like this, you will get full 3 marks. Part 2 is a little easier. You can answer based on the causes itself, where you are doing evaluation and management. So evaluation means you follow the system. So when I say evaluation, you start like first you do history. Like how much or how long have you had unprotected intercourse during the fertile period? If it's for more than 1 year, then you will think about taking some reproductive care or some reproductive treatment. Because normally up to 1 year is the window when you are reproductively or sexually active in the correct period, where you can say, okay, this much time is fine to try. But if 1 year of regular unprotected intercourse does not yield a pregnancy, then you think about male or female infertility. So we are talking about male infertility. So you take this history for how long it has been there. Is it the infertility primarily means you have never born children, or you had one child, but now you are not able to conceive? So maybe it is a secondary infertility. You take the sexual history or the intercourse history, medical history, any risk factor from the ones that we discussed, which may be responsible, lifestyle things. So this will be your history. Then you do examination, obviously general examination to look for any of the risk factors, gynecomastia for endocrine problems, or hyperprolactinemia can cause some galactoria. Those kind of things you do in general examination. Then local or genital examination for varicocele or testicular size, undescended testes, penile problems, all that you will see in local examination. Then investigation. The first investigation in male infertility or suspected male infertility is going to be semen analysis. Normally, we say after at least 2-3 days of abstinence should be there, or ejaculation should not have been done in the last 2-3 days, and then you go and give the sample. Now, they do the proper biochemical analysis where they assess volume of semen, the sperm count. Normally, sperm count should be something between around 50 to 100 million approximately. Then they look at, more important is the motility, the morphology. Are there a lot of abnormal forms, or the motility is very poor? That means poor sperm quality. To be sure, two samples should be abnormal. Okay, only then you will say there is some problem in the sperm or the semen. This is one of the ways of looking at it. So this will tell you probably some testicular problem. For pre-testicular problem and for other problems, you can do hormonal assays, right? So that will give you an idea, especially testosterone prolactin levels. Scrotal evaluation, scrotal or testicular imaging for testicular pathologies like a varicocele. Rarely ever you will have to do genetic tests. This is quite rarely done, only if you are suspecting. And the treatment is based on what the problem is. If there is no obvious problem, if you feel it is psychological, like a erectile dysfunction or something, then just counseling may be helpful. Otherwise, if it's an identifiable cause, if it is treatable, you can treat it like hormone supplementation, like you will give dopa agonist for hyperprolactinemia. If it's a surgically curable cause, nothing like it. So for varicocele, you can do varicocelectomy, right? Or last resort will be if you have no proper reason, but there is some sperm motility and some viable sperms are there, then you can do assisted reproductive techniques, right? Like a IUI or a IVF or intracytoplasmic sperm injection. So these are all common ARTs which are used for getting the pregnancy, right? So this will be the management. Even if you didn't know all this, with some common sense, you would be able to answer this. So not everyone would have prepared for male infertility, but it's not that difficult. You can answer it with your common sense.